fibrosis in RDS is something that was long recognized. As you may remember, there is also in ARDS by other causes a fibroproliferative phase, and this might actually be an aim to attack with steroids as well. The different studies, I will shortly discuss the two larger ones. This one from Modality, I think all intensivists will know it. 91 patients, of which 63 were treated and 28 were in the control group. They were in RDS for less than 3 days, and they were treated with this dose. And many beneficial effects were found in this study. A significantly shorter duration of mechanical ventilation, the length of stay in the ICU was shorter, more survivors in the ICU, and there were trends, non-statistically significant, but still trends that also hospital survival and length of stay in the hospital was beneficially influenced by this treatment. So then the larger New England Journal trial appeared in 180 patients. In these patients, they had to have more than 7 days or more of ARDS. And again, this is the schedule of the steroid that they used, or placebo. And the primary endpoint of this trial in 180 patients was mortality, and there was no difference whatsoever. So this was the negative trial to use steroids in RDS. However, of the secondary endpoints, the ventilator-free days was significantly less, so more free days in the steroid group, and also the duration of mechanical ventilation was halved. Oh, sorry, I mixed up the numbers here, I see. Was much less, 14 days against 23 in the steroid group, and this was highly significantly relevant. It's really important to realize that more than a quarter of these patients were randomized more than 14 days after the onset of RDS. And in this subgroup of patients, there were actually negative effects of steroids. What is of importance that there was, however, different baseline characteristics between these groups. So it's not really showing that there is a negative effect there because of this baseline disbalance. So following these studies, this is a study that a clinical commentary actually that you need to read. It's a must read. It's really nice how the authors are actually looking at the different aspects of the trials and trying to understand the different outcomes. So they look at the Modality trial that I just discussed, and they look at the ArchNet trial and some other trials, and they look at the different results and how they can explain that. So if you take them together, as you can see here, there is a trend, but a non-significant effect on the survival to the benefit of the steroids taken together. However, if you exclude patients that have RDS for more than 14 days, this effect does become significant. And if you look at the patients that were you exclude those with RDS for more than 14 days, and you look only at the subgroup that uses steroids for more than 7 days, because there's also a rebound inflammatory response if you stop it early, then this benefit of steroid treatment is even more clearly the case, as you can see here. So the conclusions of this part or this indication to use steroids is that there is clearly pulmonary fibrosis in patients with COVID-19. We do know from previous RDS trials that indeed there is improvement in meaningful patient-centered outcomes like duration of mechanical ventilation and ICU stay induced by steroid treatment if it's given before day 14 especially. And there are additional issues of relevance for this. You can enrich actually the population by measuring procollagen. This is a measure of fibrogenesis in the ball fluid or in the plasma. And you have to be really keen on potential complication of steroid use. And this is avoidance of neuromuscular blocking agents, infection surveillance, and avoidance of rebound inflammation. If you do this, there might be a benefit of the use of steroids in this group of patients. So my last slide and my overall conclusions about the use of steroids in COVID-19 patients is the use in refractory shock. It's unclear if in this specific group of patients, this might make a benefit like it does in bacterial sepsis patients with high doses of norepinephrine. Nevertheless, it's maybe not that relevant because we do not see many of these patients. The second part was for immunomodulation. This is very low quality of evidence of benefit. We do see possible harm in previous corona infections diseases. So my personal interpretation would be that you should not do this unless it's done in a study setting. And the final indication to treat fibrosis, clearly we do not have any data in COVID patients on the benefit or not of steroids. We do know that there is clearly fibrosis in these patients. And we do know that in other reasons of fibrosis in RDS patients, there is improvement of duration of mechanical ventilation and likely mortality, especially in those patients in which you start within 14 days after the onset of RDS. So this should be a consideration. And with that, I want to thank you for your kind attention.
Thank you very much, Peter, for your comprehensive overview of the use of the potential use of steroids in this disease. There are a number of questions on the use of steroids. Well, my perception of the problem is that we are using the evidence that we've gathered in other conditions and now try to apply it in COVID-19. But data actually from patients themselves, it's pretty vague and it's really hard to say whether this disease, COVID-19, behaves similar to septic shock or other viral infections. Now, timing of steroids, of course, apart from the different indications, timing may also make a difference. Say if we focus on the use of steroids for immunomodulation, is there anything that gives you an idea of what maybe the optimal timing would be? Is it, do you see the sweet spot maybe early or later? Any potential clues there?
No, so I think it's like a credible decrease of the role of the virus and then later on the more important role of the inflammation. So the earlier you give it, the more likely it is like that it has harmful effects because of the viral load might increase and viral shedding might increase because the virus is still very dominant at the beginning of the disease. Later on, the role of the virus has become smaller, and then the inflammatory role is larger. Yeah. So I think that later on there might be a benefit, if anything, for that. But my opinion is at this moment, for immune modulation, there is no evidence at all that there is benefit in these patients with COVID-19.
So also the use of biomarkers, because maybe some people will feel inclined when they have really biomarkers that indicate this hyperinflammation. There's not a lot we can do, of course, and often people then resort to other strategies that may work or that we've seen work in other situations.
Yes.
But also don't rely on biomarkers to select or optimally time the intervention. The evidence is just not there yet. We need to study this. Would that be your conclusion?
Yes, that is true. And I can imagine that if you would say, I have really high levels of inflammatory biomarkers, my patient is doing not good at all, this might be the model patient that might theoretically benefit most of this, but we do not have any clue that that benefit will be there on clinical endpoints.
And then specifically for patients where you would consider it for preventing fibrosis, any clues there? Should we be using lung compliance? Is there a minimal time period after which you would consider maybe still using steroids there?
Yeah, so what we in our clinic do is we consider steroids in those patients that over the course of their disease we see a change in their compliance, for example. Their lung mechanical pressures are changing. So you have a clue that there might be a more stiff lung, and fibrosis is actually giving clinical consequences. And we measure this biomarker procollagen in the blood because we do not do bronchial alveolar lavage in these patients many times, of course. And this is also a marker that we know is not really sensitive, but it is a little bit more specific. And so if we do see an increase in this marker and the lung mechanics are also changing, then we do treat these patients with steroids.
Okay, thank you very much, Peter. I think we'll end here. I think this was very interesting presentation and basically showing that we need more information about the use of steroids, although I think a lot of people are using it at this moment. Thank you very much, Peter. Back to you, Armand.
All right.
Okay, well, I will end this session here. I will just mention that we had a very interesting session, and it's very clear it's a challenging disease with several phases in it. We heard about the inflammation and the endothelial damage and the coagulopathy that we see during also the cytokine storm. And it's very clear that we have learned from the previous period that we should be very watchful for thromboembolic disease with a very low threshold for diagnostics and therapy for it. And what we learned from the last speaker, Peter Pickers, is that the timing of giving steroids, and we did not discuss the dose, but the timing of steroids is also very, very important. And there is no evidence whatsoever that we should start it very early in the disease. And I think all this experience will help us to establish some sort of standard care, because as a lot of people and a lot of you probably would expect, there will be a next wave, and then it's very important that we have established some sort of standard cares that we can compare to. Having said this, I want to thank you all very much for your attention, and we will continue our program. Thank you very much.
Thank you.
I'm an anesthesiologist and I'm proud to be an intensivist. We, intensivists, are working together to fight COVID-19. Together, we are intensive care medicine.
Hi, I'm proud of being an intensivist. We are fighting COVID-19. Together, we are intensive care medicine.
I am an anesthetist and I'm proud to be an intensivist. We are working together to fight COVID-19. Together, we are intensive care medicine.
I am an intensivist and proud of it. Intensivists with various specialty backgrounds work together as a multidisciplinary team to prevent and treat temporary risk of death due to COVID-19.
My name is Jan de Waele and I'm proud to be a surgery-trained intensivist and work in intensive care. We work together to beat COVID-19. Together, we are intensive care medicine.
You are in live.
Hello. This is Derek Angus speaking from the Pittsburgh, and I'm here with my colleague Howard Boschner from the Chicago office of JAMA, and both of us work at JAMA. I work for Howard. Howard is the editor-in-chief, and I'm the associate editor for critical care. And on behalf of Howard and I want to say it's a delight to be here. We love working with ESICM. This has been an incredible session so far today, and we look forward to bringing you 3 great speakers over the next hour. Howard?
So just a couple brief comments. It is a privilege to be here. I want to thank Josef and Maurizio, and I wish all of my colleagues around the world, particularly intensivists, other clinicians, the best, and that they still stay healthy. It's rare in your lives that you get to participate in the care of so many ill patients and save lives on a daily basis. And my respect for the discipline and for all of the healthcare systems around the world is immense. 1 or 2 brief comments before I introduce Preethi. People often ask. We're getting about 100 submissions a day. All of the research letters go to Jody Zelke. I review all of the viewpoints, original investigations, brief reports, and along with Derek, Eli Provanovich, Gordon Rubenfeld, and Preethi, as well as the senior staff, help make decisions about which papers will go forward. It's been an extraordinary opportunity. The JAMA content has had about 25 million views over the last 2.5 months. A number of our articles are well over the 1 million views, and the live stream that I did with Maurizio has close to 1 million views, and as I've said before, both privately and publicly, I think galvanized the world around this pandemic. I think people recognized it was going to be a huge issue, and I think that live stream video, as much as anything else, convinced the world that we were facing an enormous crisis, particularly in critical care. So with that, I'd like to introduce the first speaker. She's a friend and a colleague. It's Preethi Malani. She's a professor of medicine and infectious disease at the University of Michigan. She's our associate editor in infectious diseases. She also edits the Peace of My Mind section. And then finally, she's also chief health officer for the University of Michigan, and is advising the president of the University of Michigan about how to bring 50 million or 50,000 students potentially back to the campus in the fall. So a great deal of experience and a great deal of responsibility. Preethi.
Thank you so much. Thank you, Howard and Derek, and also thank you to the ESICM organizers for inviting me to this special virtual half marathon. It's probably the best kind of half marathon. I'm proud to represent JAMA as an associate editor and also to represent the University of Michigan, where, as you heard, I'm a professor of infectious disease. If I were to give this talk a month from now or even a few weeks from now, it would undoubtedly look different, which is a reflection of just how fast things are moving in the treatment arena. At the same time, we really are not sure that the treatments we are using in severe COVID infection are in fact effective and safe. And everyone is waiting on better and more definitive data, especially from large multi-center randomized clinical trials, which are fortunately, many of which are underway. I'd like to set the stage with 2 viewpoints that take a broad approach on this need for evidence for therapies and guidelines. The first comes from Dr. Andre Khalil from University of Nebraska, and it's titled Treating COVID-19. Yes. My what? What is out? Oh, it's not out? Oh, I'm sorry. Let me see if I can apologize. Okay, is it on now? Okay, thank you. So this first viewpoint is treating COVID-19 off-label drug use, compassionate use, and randomized clinical trials during pandemics. And Dr. Khalil reflects on that essential need for randomized clinical trials and treatment for really any future outbreak. And he makes several important points. the first, he talks about the 2014 Ebola outbreak, which basically all the studies were done without concurrent controls. So in the end, we really didn't have any definitive conclusions regarding efficacy or safety. Second, many of the drugs that are looked at look promising in vitro, but then when they are in clinical studies, they've failed. And third, and this is very important, is compassionate use therapies that have not previously been approved, for example, remdesivir, could have serious adverse effects that were not previously identified. And he concludes by saying the rapid and simultaneous combination of supportive care and randomized clinical trials is the only way to find an effective and safe treatment for COVID-19. The second viewpoint actually comes from Dr. Derek Angus, as well as Dr. Francois Lemontagne. And this addresses the Surviving Sepsis Campaign guidelines, which of course the audience is very familiar with. This is the management of critically ill adults with COVID-19. It was initially published in March. And those guidelines remarkably had 50 or more recommendations under 4 domains and created a concise summary of the evidence. It also helped to reduce variation in clinical practice very early in our experience. But it's what's not in the guideline that's important for today's discussion. And the authors write implicitly, the guidelines also suggest the need for specific research effort. In 6 instances, the panel makes no recommendation because evidence was deemed insufficient. In other instances, the panel issued weak recommendations for or against specific therapies. And again, this viewpoint highlights those gaps and the importance of them, which brings us to the research articles that I'd like to briefly share. And for this format, I'm going to stick with just showing some key figures and talk about some of the key findings since our time is so limited. I would like to remind everyone that all of the coronavirus-related content across the JAMA network is available free without paywalls. It is at jamanetwork.com. And before the talk this morning, I also took the opportunity to tweet out the links for all these articles. So this beautiful figure comes from an article by Sanders et al. And it's a review of the pharmacologic treatments for coronavirus disease 2019. And I'm not going to discuss the content except to show this figure as an illustration of the viral life cycle and really all the many potential drug targets, including non-structural proteins, as well as viral entry and immune regulation pathways. And if you look closely, you'll see a number of agents that are depicted here that are currently in different stages of clinical trials. This was published in April, and it is in this week's print edition for those of you who like print, like me. The first study is from Dr. Eli Rosenberg and colleagues, and there has been a lot of interest in hydroxychloroquine and with or without azithromycin as a possible therapeutic agent for COVID-19. However, the data are limited, both for efficacy as well as for adverse events, and some of those concerns include prolonged QT and arrhythmias. And this paper does a nice job of addressing some of those issues. This is a retrospective cohort study. It's more than 1,400 patients who were hospitalized with a diagnosis of COVID-19. And this was from 25 hospitals across metropolitan New York. It's obviously an observational study, and the primary outcome the authors were interested in was in-hospital mortality. Of note, those receiving hydroxychloroquine were, as well as azithromycin or both, were more likely to have diabetes, a respiratory rate of greater than 22, abnormal chest imaging, and oxygen saturation lower than 90%. So these were patients that had more severe disease, and they were at baseline a little bit different. This is the table that shows unadjusted treatment outcomes, and I just highlighted one here, which is death. And overall in-hospital mortality was 20.3%. And the unadjusted death rates were higher among both patients who got the hydroxychloroquine as well as the azithromycin and hydroxychloroquine, and hopefully you can see those. The adjusted data is important to look at, and this is a Cox proportional hazards model. And this was adjusted for demographics as well as pre-existing conditions and illness severity. And when that was done, compared with the neither drug group, which is sort of in the middle here, None of the 3 treatment groups had statistically different rates of death. So there was not a mortality difference, and there also wasn't a higher rate of death in treatment. So I just wanted to show this because I think this is, for me as a clinician, this is very important. This is the adjusted logistic regression models, and compared with patients receiving neither drug, cardiac arrest was significantly more likely in patients receiving both drugs, hydroxychloroquine and azithromycin, and the adjusted odds ratio was 2.13. This was not seen in the drugs used individually. And again, this is just important to note, this observational study, and hopefully we will have more data on this to guide this. There were not differences noted in abnormal EKG findings. And the authors conclude that among hospitalized patients with COVID-19, treatment with hydroxychloroquine, azithromycin, or both, compared to neither treatment, was not significantly associated with differences in in-hospital mortality. And the lack of observed benefit, it's consistent with what has been seen in other observational trials. Now, the clinicians, we're waiting on the randomized trials, and there are multiple going on, including the ORCID trial, which is of interest to this group, as well as the HERO trial, which looks at post-exposure prophylaxis. So the story is not done, but I know that at my center, we're not using these drugs outside of clinical trials. I did want to go on to this article, and I really like this article a lot. This is from Shen et al. This is a preliminary communication. It's a case series of 5 critically ill patients with COVID-19 who had laboratory confirmed disease, and they were treated in Shenzhen, China, using plasma from individuals who had recovered from infection. And when this was published, which was on March 27th, which seems like a long time ago now, this was the largest and really best described experience to date. And I still feel that there are a lot of really nice details in this paper. Certainly the use of convalescent plasma is not new. In fact, it's very old, but there's a lot of new interest in this modality. There was interest in this during Ebola, as well as during SARS-CoV-1. And that interest has been rekindled as a therapy for severe COVID-19 infection. And again, this was 5 patients, and they're shown here in this table. They all had severe respiratory failure. They had ARDS. They were mechanically ventilated. One of the patients was on Ecmo support. And as you note here, 2 of them also had concurrent bacterial and/or fungal pneumonia. These were patients who had been in the hospital for quite a while, and they were quite ill, not unlike the type of patients that many of you see and that I see on a regular basis. 4 patients that did not have coexisting medical conditions, they received the convalescent plasma around day 20 of their hospital stay. And the 5th patient, who did have some underlying hypertension and mitral insufficiency, received it on day 10. The donor plasma was shown to have IgG and IgM, anti-SARS-CoV-19 antibodies, and neutralized the virus in vitro culture. All 5 patients recovered, and their clinical status improved around 1 week after transfusion. And the use of convalescent plasma may or may not have contributed to this recovery. Again, it's hard to say since it's such a small number, but this figure is also a really nice figure, and it represents some very clinically relevant endpoints, including the SOFA score, which came down over time, the PaO2 to FiO2 ratio, which improved, and of course, body temperature with fever, which resolved. And this panel A looks at the cycle threshold, which is a measure of how much virus can be detected on nasopharyngeal swabs. A higher threshold means less virus. So this was also moving in the right direction. In addition, the patient's neutralizing antibody titers increased after transfusion. Again, small numbers, but you can see that the IgG, IgM, and neutralizing antibody titers all did increase. In the United States and really around the world, the use of convalescent plasma for COVID-19 is really increasing. The interest is increasing. This is an investigational product in the United States. It's not approved by the FDA. And there's growing interest in this. We are mostly using this in the setting of very severe infection in patients who are critically ill, but there's also some interest in using this as prevention in high-risk essential workers, including healthcare workers. We really don't know much beyond anecdotes at this point. And within the past couple of days, there were safety data on 5,000 patients that was placed on a preprint server. This was interesting because overall it showed pretty good safety. There were a few deaths that may have been related to the transfusion, but again, this is where that randomized trial data is going to be interesting, and just better, bigger studies will help guide hopefully when and how to use convalescent plasma. This is not a manuscript, it's a press release, and I know everyone has seen this and everyone's waiting for the full study to be published, but it's an example of preliminary results that were initially presented in the popular press and social media, not as a published manuscript. This is a reflection of where we are with COVID, that things move so quickly, but it's also a reminder that speed is good, but details are better, especially to make thoughtful choices around clinical care. And around the United States, remdesivir has been really very high on our minds, including some difficulties getting access to this drug and trying to figure out how it's distributed. My hospital does have dosing for several patients, and we have created some criteria around how to allocate this. Much like the hydroxychloroquine a month ago, this has gotten so much attention that we are seeing patients present and their families ask about the use of this drug. And I'm going to end with this viewpoint that's written by two of my favorite people, my mentors at JAMA, my friends, including Dr. Howard Bachner, who is moderating this session, as well as Dr. Phil Fontanarosa. And I would just, in the interest of time, I would encourage all of you to read the full viewpoint. It's beautiful. Every word of it is powerful. It includes a number of suggestions for encouraging investigators to really move the science. And one of the suggestions is for investigators to share patient data if they are working on similar trials with one another, even if the analysis of the combined data is not pre-planned and would be considered exploratory. Another important message that I really like and that resonates with me is that treatment is treatment. And even if treatment trials show efficacy, treatment is not prevention. And so we do need to consider prevention. I will leave you with this beautiful sunrise from lovely Michigan. This photo was taken near my home. This is the longest couple months that I can remember. And I know it's been even longer for all of you who are on the front line in critical care, intensivists, my pulmonary colleagues. And it's going to unfortunately be this way for a while. I want to thank you for everything that you've done for our patients, really for our colleagues, for our communities. But I also want all of you to take a moment to take a breath and hopefully take care of yourselves. And with that, I will stop.
Can you hear me?
Yeah.
Great. So there are a number of questions, but we're short on time. But you went through hydroxychloroquine, our article. There was one in NEJM, and I think at least at this point, the data would suggest its use should only occur within a randomized clinical trial. You mentioned the NIH press release, a mortality benefit of 3 or 4% within the clinical trial. We'll see what the ultimate report shows. But the other drug that continues to get an incredible amount of attention, and I know you've used it at Michigan, so I call it TOSI because I don't pronounce drug names very well, but can you comment on your sense of TOSI?
Yeah, I call it TOSI too. So we have pretty strict criteria in the use. And again, I think it's if you ask us, we'll say, oh, it seems to work. But again, I think it's a selection of who we choose to treat. We work closely with our critical care colleagues to try to get at patients, again, before they're intubated, before they have decompensated clinically. And we're treating people that we feel, whether it's right or wrong, are more likely to do better, and limiting treatment in patients who maybe are not going to do it quite as well. But it is interesting. It comes with a cost, not just a money cost, but the risk of pneumonia appears to be higher, and that's been seen in observational data by other places too.
Thanks, Preeti. I'll just make a final comment, and then I'll turn it back over to Derek. we have gotten between 5 and 10 papers, observational studies, small case series of 25, 50, 75, with respect to the use of TOSI. And all of them have been rapidly reviewed internally, and none of them have made it to publication, in part because of the imbalance of who's getting the drug and who isn't. And in many of the studies, virtually all of them, what our statistical and methodologic reviewers have indicated are implausible effect sizes. And so, you know, Derek and you and Gordon have participated in those discussions. So every Wednesday, we review the most recent original investigations that have come in. And despite my wanting to go ahead with one or two of them, I've been persuaded that they're not the best studies to publish in JAMA. With that, Preeti, you've been fabulous. Thank you for everything, and I'll turn it over to Derek.
Yep, thank you guys.
Bye, Preeti.
Bye.
Thanks, Preeti. And yes, I would just echo that. It's really, really hard to tell whether drugs like TOSI are going to work based on observational studies. So hopefully we'll have some good RCT evidence in the coming weeks or months. So let's pivot to another aspect of critical care, and that is to think about how to manage the respiratory failure that accompanies patients in distress with COVID-19 disease. And it's really our delight to invite someone incredibly well known already to the ESICM community, Laurent Brochard, originally in Paris for many years, but of course in the last few years has been the director of the incredibly well-known sort of interdepartmental division of critical care at the University of Toronto. He's a former editor-in-chief of intensive care medicine. He's a long-standing associate editor at the Blue Journal, and he's really one of our preeminent experts in respiratory failure, both under non-invasive and invasive settings. And I couldn't think of a better person. A perfect delight for me to invite my friend and colleague, Laurent Brochard, to speak on the really interesting question of prone positioning in patients with COVID-19 who are still spontaneously breathing and not necessarily intubated. So Laurent, over to you.
Okay, thank you so much. Thank you, Derek. Very kind introduction. Thank you both Howard and Derek for the invitation, and to ESICM. So I'm very happy to discuss about a couple of studies which have been published in the JAMA about this question of prone positioning during spontaneous breathing. So as a way to treat or to prevent, has already been discussed, the outcome of respiratory failure. And this is an editorial we wrote with Irene Telias from Argentina and Bhushan Katira, who is a pediatrician in Toronto. So the question was, is the prone position helpful during spontaneous breathing in patients with COVID-19? I have to say, JAMA has published a lot of information about COVID-19 and really nicely tried to adapt to this incredibly challenging situation. One of the interesting recent clinical update was, it's called like that, it's from John Marini and Luciano Gattinoni, and I think it has been, a lot of attention has been paid to this paper. I'm not going to go into details, but it describes what they think could be an interesting management of COVID-19 respiratory distress. One thing I was a bit surprised was that they used a new acronym, was that they say, okay, let's call this patient CARDS. But then I looked back at the literature and I saw that the guy who discovered the ARDS, Tom Petty, said in the CARDS was ARDS, so that's fine. So one thing they mention in their paper is that it may be possible to use awake prone positioning as a respiratory support options. And I have to say there have been some studies already published on this issue out of the COVID-19 epidemics, but really very few data. So it's very interesting to look at these studies, which are small studies, which have the limitations of studies done in urgency, but which give nice information. So the first letter from Milan, Dr. Sartini and colleagues, gives very impressive result. You see the nice figure here where you have the change in SpO2, the change in PaO2 over FiO2, and the respiratory rate change. Importantly, this is during non-invasive ventilation. So these are patients who have been already on non-invasive ventilation for 1 week. So this may not apply to every patient arriving in your emergency department, ICU, or on the ward. And the question was really, does it improve the efficacy of non-invasive ventilation? And from this data, we would tend to say, yeah, it looks really nice improvement in oxygenation, which is consistent in terms of SpO2 and ABG, but also an interesting decrease in the respiratory rate. And why this is interesting, because you may think that even if you don't change the amount of work of breathing performed per breath, if you breathe less per minute, the total amount of oxygen consumed by your respiratory muscle may go down. But we are not sure exactly whether this is specific to NIV and what were the NIV settings. There's another paper which is maybe, I would say, probably more realistic compared to what we may observe in the clinical setting, from a French group from Aix-en-Provence and Marseille with Laurent Papageno. And you have here the PaO2 before, during prone positioning. Again, it's a non-intubated awake patients being voluntary to do the proning. And you see that the response is not that spectacular and not consistent. So they called patients responder, non-responder, and a few of them, only 4 of them, it's again a very small series, are persistent responder, which means after coming back to the supine position, they keep the improvement in PaO2, FiO2. So just to summarize, the 24 patients who agreed to participate, 4 did not tolerate prone positioning for more than 1 hour, and in fact were intubated in the following hours. 5 tolerated from 1 to 3 hours, and 15 tolerated for more than 3 hours, which is encouraging because it's a majority of the patients. And the patients who were responder were the majority of the patients who sustained prone position for more than 3 hours. So this is what we see and what we know. So maybe I'll take a few minutes to go back to what we have been described, what have been described about prone positioning in classical ARDS, if I can say so. And one of the things we discovered really with prone positioning is that the major reason for the distribution of the consolidation, the injury in patients with ARDS is gravity. And when you change this force, this gravity, you change the distribution of lesion, which is quite extraordinary. So this is why people mention the lung acting like a sponge. And one interesting aspect which we have to keep in mind is that there is a very, very frequent benefit on oxygenation, which may not be related to anything else than the anatomic distribution of perfusion. So this was a nice physiological study in animals, so it may not completely be the same in men, but what you see is the distribution of perfusion when the animals are supine and are prone. And what's interesting is that in supine position, most of the perfusion is on the dependent area, which are not ventilated, so that explains a lot of the shunt. But when the animals are prone, the distribution is still predominant in the same zone, which is now non-dependent. So it's much better with ventilation. So by anatomy, I would say the gravity does not influence perfusion in the same way than ventilation, and that explains a better matching of ventilation perfusion ratio, which explain the benefit in oxygenation observed, independently of any other effect like lung protection. Because the other effect we are looking for is lung protection. One interesting observation was the fact that when you put the patient, this is patient now, prone, you put the flexible part of the chest wall on the bed, and in a way you rigidify, you make the chest wall stiffer. And this helps to have a more homogeneous distribution of ventilation. So this effect may be protective for the lung. And because it's protective, you need to do it for a long time. There have been a number of studies which initially found benefits in oxygenation, but no effect on survival, for instance. And I show that because there was a meta-analysis of this study which showed that maybe there is a trend for a benefit associated with the duration of prone. And indeed, it's the study by Claude Guérin in France who decided that patients should be prone for as long as possible, and on average it was more than 16 hours a day. And this probably is a major factor which explains this beautiful effect on mortality in patients with ARDS. So, and this was in Claude Guérin's study, the duration, you see 17 hours on average. So why would we do prone positioning in patients who are spontaneously breathing? Well, one reason may be to increase oxygenation. Another reason may be to prevent the lung, to protect the lung from possible injury. We have described that patients who have a high breathing effort and high respiratory drive may worsen their lungs, and we have called that patient self-inflicted lung injury. Of course, it's unintentional self-inflicted lung injury, if you wish, but it's the drive, the brain is so much stimulated by impaired gas exchange mechanics and inflammation that the amount of effort is generating harm for the lung because of the amount of stress and local strain in the lung. And the potential benefit of prone positioning may be again to have a better homogeneous distribution of ventilation, less strain, and protection from these patients' self-inflicted lung injury. So from these two small studies, it's hard to have very strong conclusion. The first question is, can prone position prevent intubation? And we clearly have no response. But although this question is essential, it's important to keep in mind that intubation is a medical decision, not a physiological state. In other words, for instance, you may prevent intubation because the numbers in terms of oxygenation look better, and the clinicians may be less prone to decide to go for intubation based solely on hypoxemia. Maybe it's a good thing, but what we really need is to understand what this technique of positioning is really doing for the patients. What we see from these small studies that the clinical tolerance is sometimes a limitation of the technique. You have seen a number of patients who do not tolerate, and of course the patient has to accept it. The physiological effects are not clarified. Do we decrease these, the stress on the lung, the regional risk of injury? And also, you know, compared to what we have seen in ARDS, are there any benefits of these very short sessions? So I would say it's exciting, it's promising, but it's still very preliminary. But it's really great that people are starting to look at this technique, because it's a technique that anybody could do, and if there is benefit, it's clearly worth exploring this technique. Thank you. I stop there and be happy to address any question.
Thank you, Laurent. That was fabulous, as I expected. So, so we don't have large-scale randomized trials. We have these 2 reports and a few other reports, and of course, all over Twitter, people are talking about proning awake patients on CPAP, etc. So what would you tell someone to do if they see someone tomorrow? If someone comes into your hospital in Toronto tomorrow, are you supporting delaying intubation and doing a little bit more use of non-invasive and trying proning to see if it improves oxygenation before intubation? Or do you think there needs to be a trial? Or what would you do Sunday morning?
Yeah, good question. And I would encourage people to have as much monitoring as possible to try to understand. We, for instance, have a new technique called the electrical impedance tomography, which is a non-invasive technique where you see the distribution of ventilation in the lung. So if you could do that and watching it, this may give you information about what's the benefit. I would just be cautious about using it on the floor without careful monitoring, because as you mentioned, this may be simply delay intubation because the oxygenation looks good. So I would say, as everybody you discussed already this morning, this should be done as much as possible in the context of a clinical trial. I think it's worth doing these trials. I know of 2 already ongoing, so I would encourage people to participate in this trial. If they want to do it, I would monitor the patient as closely as possible. The information we got about the respiratory rate is an interesting one. Although during non-invasive ventilation, you may have false changes in respiratory rates, so I don't think we know enough. So 1, go into a randomized trial. 2, if you do it, monitor your patient as closely as possible, because there is a real risk of delaying intubation just because the numbers look better.
And presumably, although you discussed the 2 mechanisms that could lead, the 2 broad mechanisms that could lead to overall patient outcomes, presumably that immediate benefit in hypoxia is almost certainly because fluid distribution in the lungs redistributes while perfusion remains relatively similar, and so you get a short-term immediate improvement in a decrease in VQ mismatch, correct?
Yeah, the other effect I didn't want to go into detail because we don't really have the data, is that the position of the diaphragm is situated dorsally, mostly the muscular part of the diaphragm, not the crural part, and therefore the way the diaphragm is working may be different in the prone position and may also affect the distribution of ventilation. But you're right, yes.
So does that mean in your mind that these patients who are having problems with hypoxia have also lost their normal hypoxic pulmonary vasoconstriction? And that's part of the problem, is that they can auto redistribute?
Yeah, I think this is one of the basic component of ARDS, that vasoconstriction is certainly not perfect. There is always imperfect pulmonary vasoconstriction. Whether it's more pronounced in these patients, I don't know. We have so much report about, one of these complicated issue with all this aspect of physiology is how rigorous you are in the measurements you do. And I've seen a lot of report about vascular effect, and which to me are not well documented yet. So I think this loss of vasoconstriction has been always described in classical ARDS, so it certainly exists here. Whether it's more pronounced, I'm not so clear. And the small reports we have about inhaled NO were not very spectacular, for instance, in this regard.
And I'm going to leave you with a final question then. So am I right in thinking that if I were to ask you the question, does prone positioning in the awake non-intubated patient help or hurt in COVID-19, you would say yes, that it might help some patients and hurt others?
Yeah, and so the other thing is that I do love physiology, of course. I think it's very important. But every time we talk about patient management, we have to deal with clinical decision making and how it's how things are decided. So it may help physiology, but be careful it does not harm the patient because you take the wrong clinical decision.
Right.
This is an easy way to respond poorly.
Okay, Laurent. So I have to say, on behalf of Howard, myself, and ESICM, as always, it's a delight to listen to you speak, to hear your wise words. Get back to the ICU. I know you're having a busy day, and we will move on to the next speaker.
Okay,
Thanks,
thank you so much, guys. Thank you very much. Thank you.
And then, Howard, do you want to introduce our next speaker, our friend and colleague?
Well, he's your colleague, so I think it best that you introduce him. But I would say Doug has tread into one of the most complicated issues that has arisen in the United States, and I suspect around the world, with enormous emotional attachment to it. And that was the concern in the U.S. that there would initially be restrictions on the number of ventilators, and they would have to be rationed. And now it's quite clear that drugs may need to be rationed. And so this has become a hugely important issue, not only in the United States about how we do it, but in every country around the world. But I'll let you do the formal introduction.
Sure. So it is, of course, with great pleasure that I introduce my friend and colleague, Doug White, who many of you know. He's he's both an intensive care clinician and researcher, and also an ethicist who thinks both about conceptual ethical issues and also thinks about both empiric and experimental research in this area. And he has, he currently works at the University of Pittsburgh in the same department I work in. He holds the endowed chair in ethics in critical care medicine, and he runs our program on ethics and decision making in critical care, and is a professor of critical care medicine and translational science. And I would say that, just as Howard said, Doug has thought in an has brought incredibly rational and compassionate thought to an incredibly emotionally charged area about allocation of scarce resources, which initially was framed as ventilators, but with the recent suggestion that remdesivir may help, there's now a worldwide mismatch between potential supply and demand. And so Doug is going to speak about the fair allocation of scarce resources during this pandemic. Doug, over to you.
Derek and Howard, thank you so much. And hello, everyone. I hope everyone is staying safe. So as Derek and Howard said, I'm going to be addressing two JAMA papers, one that addressed the fair allocation of ventilators and ICU beds, the other that addressed the fair allocation of antiviral medicines during the COVID-19 pandemic. And, you know, honestly, the first time I think many intensivists in the world got a really clear view that scarcity of ventilators is a real thing in the West was the JAMA Live interview that Howard did with Professor Ciccone now a little bit more than 2 months ago. And I watched this live at the time, and I remember when Professor Ciccone talked about just the unbelievable volume of patients with acute respiratory failure coming in, and essentially, you know, 50 patients a day to a single hospital in need of a ventilator, the kind of numbers that many of us never have seen anything close to in a single day. And so, you know, I think it drove home the reality that scarcity of ventilators for people who will die without them is something that we may need to face. And so we published about 3 weeks later a framework in JAMA for rationing ventilators and critical care beds. And this framework really dated back to work that we started in the H1N1 pandemic in 2008, 2009, largely in response to the existing professional society guidelines at the time that were published in CHEST by the Task Force for Mass Critical Care. And the framework that they published, and this is a group of friends and colleagues, so I respect and agree with the vast majority of things in this document, but one of the things that I really struggled with and a number of colleagues struggled with was that the rationing approach started by excluding large groups of patients from access to ICU care. So patients with cognitive impairment were excluded, patients with neuromuscular disease, patients with metastatic cancer, even patients with moderate but not terribly severe heart failure were excluded from ICU access. Yet patients with COPD on oxygen would have been excluded, and patients who were greater than 85. And I think many people looked at that and said, you know, these are concerning from a fairness standpoint to simply exclude people. And in the United States, we have recently had a very big uproar around the state-issued guidance from states like Alabama that essentially do a similar thing in which they recommend not offering mechanical ventilation to patients with, and these are their words, severe mental retardation, moderate to severe dementia, class 3 or class 4 heart failure, or again, COPD requiring home O2. And I think there are some real ethical concerns with using diagnoses to exclude patients from access to ICU care. First, I think it's really the wrong tool for the job because most chronic disease states are not sufficiently predictive of a poor prognosis to reliably exclude patients. And for me, the cleanest example of that is imagine a 50-year-old patient with moderately severe heart failure who's admitted not with a CHF exacerbation, but with an opioid overdose. And all he needs to survive is, 7 or 8 hours of mechanical ventilation and some Narcan, and he'll walk out of the ICU the next day. According to these existing guidelines, that patient would have been excluded from access to ICU care. Second, I think this approach sends a concerning message that there are just some lives that are not worth saving. And then finally, using these broad exclusion criteria violates a fundamental principle of public health ethics, which is to use the least restrictive means possible to accomplish the public health goal. So if there's a less restrictive way to do this, we should. And so we, in the framework in JAMA that we proposed, we first outlined what we think are 5 points of general agreement. And I'll just run through those quickly. The first is that rationing of ventilators and ICU care should be considered the option of last resort. And hospitals have a strong ethical obligation in a public health emergency to first do everything they can to increase their hospital's ability to care for more and more critically ill patients, and also to cooperate regionally to transfer patients from more busy to less busy hospitals. Second, during an emergency, there needs to be a shift in focus to population outcomes rather than solely on what individual patients would choose for themselves. Third, a triage officer, not the bedside clinician, should make these triage decisions. And this triage officer needs to be very well trained, both in the allocation framework and also in things like implicit bias and disability rights to avoid discrimination. Fourth, there are a variety of characteristics that should be viewed as irrelevant when making triage decisions: gender, race, ethnicity, religion, disability, perceived quality of life, citizenship, and social connections are among those things. And then finally, triage will almost certainly involve not only the initial triage decision about who gets a ventilator, but also re-triage and the notion of withdrawing life support from patients with a poor prognosis to provide it to patients who are much more likely to survive. Clearly an ethically and emotionally challenging thing, but one that is necessary to maximize population outcomes. All right, so then what about the substantive criteria to determine who should get an ICU bed? And I want to start by just pointing out work that Lee Biddison-Doherty at Johns Hopkins did in the 2010 to 2015 time period. She engaged a large group of citizens in the United States and actually, in a very careful, deliberative, democratic way, took to them the question of which principles should guide allocation. And essentially what she found is that there were 4 main criteria that citizens believed should often be used in allocating scarce resources. Who's most likely to survive the current illness, who's likely to live longer, which is to say patients who don't have an end-stage condition that will kill them anyway. Interestingly, patients who have lived through fewer stages of life, which is to say giving some priority to the young compared to the old, and then also giving priority to essential workers, that not only clinicians, but also individuals who maintain public order, work in food services, other essential businesses during an emergency. And I think really importantly, the overwhelming majority of patients rejected a simple random lottery as the way to distribute scarce resources. So the ethical framework that we outlined involved essentially balancing our commitments to social justice while appropriately storing scarce resources. And what that means operationally is that all patients should be given a chance to receive treatment, which is to say no exclusion criteria above and beyond the criteria we already use to say a patient is, for example, too sick to benefit from ICU care. Second, to ensure that all patients receive an individualized assessment rather than, for example, looking at a disease itself and making a judgment about their prognosis based on that. And then third, it's important to take proactive steps to diminish the impact of social inequalities that negatively impact patients' outcomes. And I'll say a bit more about this at the end. So the substantive criteria that we recommended are saving lives, so maximizing survival to hospital discharge, with some attention also to duration of benefit and selecting patients who are not expected to die in the near term from a chronic condition, and then also giving some priority to essential workers and to the young. So this is a framework that involves multiple principles, and you can imagine that sort of combining them into one allocation strategy could be quite difficult. And what we proposed is a multi-principle point-based allocation system with the two main criteria being saving lives and saving life years. And the way we specified both of those criteria were first looking at the patient's prognosis for hospital survival with a validated severity of illness score. And here we use the SOFA score, but we don't necessarily recommend it. And I think there's increasing data to suggest that it may not be adequately predictive of outcomes. But this is just illustrative to say patients are grouped according to their SOFA score and given points on a 1 to 4 point scale, with fewer points being higher priority patients. And then second, for saving life years, we specified that as the prognosis for near-term survival. So if patients have a disease that is associated with death within a year, they get 4 points. If they have a disease where death is expected within 5 years despite successful treatment, they get 2 points. And what this yields is a score on a 1 to 8 scale, with lower scores meaning higher priority. We also proposed that there are 2 tiebreakers. Essential workers could either have a point deduction, so get somewhat heightened priority, or the essential worker status could be used as a tiebreaker. And as a tiebreaker, we proposed life cycle considerations, which is to say some priority going to younger patients compared to older patients, not because of social worth, but because the young are the worst off in the sense that they've had the least chance to live through life stages. And I should just point out that the full allocation framework that we developed can be reached here. It's an appendix in the JAMA paper, and we give much more detail on these considerations. So this framework, after the JAMA publication, was relatively rapidly adopted and now has been taken up as the state guidance in California, New Jersey, Massachusetts, Pennsylvania, Colorado, and Oklahoma. So I think, you know, a real tribute to JAMA for disseminating the ideas. All right, shifting gears. Last night, JAMA released another really important paper, an ethical framework for allocating scarce inpatient medications. This is by Colette de Jong, Alice Chen, and Bernard Lowe at the University of California, San Francisco. And there are many similarities in the 2 frameworks for allocating ventilators and ICU beds, as well as inpatient medications. This is, as Derek and Howard already alluded to, incredibly timely because the Gilead CEO has released remdesivir broadly, and many hospitals are now both trying to get doses and trying to figure out how can we allocate this fairly. I just want to flag that remdesivir is merely an example of scarcity. There are likely other therapies that will come online in the coming months, hopefully will come online in the coming months, including convalescent serum and monoclonal antibodies that we expect will also be scarce for a time. And so the ethical goals that De Jong and colleagues outlined are here. There were 5 main goals: prioritizing saving lives, saving those with a good near-term prognosis, prioritizing essential workers, avoiding discrimination, and mitigating health disparities. And I want to just drill down on two of these to end. So prioritizing, or what do they involve for strategies to save lives? Well, first, they recommend that during periods of shortage, that use of the drugs should be restricted to patient populations where the efficacy is proven in the RCTs. So really sticking very close to the inclusion and exclusion criteria. Second, avoiding compassionate use for other indications, because these indications outside of what's been proven are likely to not be as effective to what has been proven in the RCT. And then relatedly, the authors strongly encouraged authors to not use anecdotal evidence to prioritize within the trial populations. And the logic there was that overall predictors of prognosis from COVID-19 may not actually predict the efficacy of a new drug, which is to say, we may as intensivists have an impulse to say, boy, my patient is critically ill with 2-organ failure. Clearly, they're going to benefit more than the patient on high-flow nasal cannula, and I should give them the drug. But there are no data for that right now. And I think we need to wait for those subgroup analyses before we start to try to make predictions of who's going to be most benefiting of the drug in the subgroups. All right, so on to this last question of strategies to mitigate health disparities. I must say that this is a really controversial and important point. In the paper, De Jong and colleagues articulated 2 ways to do this. One is prioritize essential workers, but construe that category very broadly to mean not only doctors, nurses, respiratory therapists, but also the full chain of people who are involved in maintaining social order during an emergency. So people who work in retail, who are in maintenance and sanitation, people who work in restaurants, all of these people should be prioritized. And it's worth noting many of them are persons of color. So this is a kind of an indirect way to mitigate health disparities. They also explicitly noted that triage teams should be trained in techniques to avoid discrimination based on gender, race, ethnicity, perceived quality of life. And this is really where they stopped. But I would just like to point out that if we're truly going to mitigate health disparities, we actually are going to need to prioritize hard-hit groups. And some of the hard-hit groups are listed here. Latino and African-American patients are dying at twice the rate of white patients. So this is a true health disparity. And if we're to address this, we need to think carefully about how. And I'm just going to end by showing you sort of a thought experiment. Let's say that 50% of the patients that you see in your ICU with severe disease are white and 50% are black. You might say, well, listen, the fairest way to treat these patients is simply to give half of the scarce drug to the white patients and half to the Black and Latino or Latinx patients. If you did that, you may be missing a really important part of the epidemiology of disease, which is to say that 50% of cases arising from Black and Latinx patients is coming from a small proportion of the population. Let's say it's 25% of the population is Black and Latinx, but they're accounting for a disproportionately large number of cases of severe disease. So if we're truly to try to remedy what appears to be a large imbalance in deaths by race and ethnicity, we actually will need to take a proactive step that probably looks something like giving some extra priority to treating Black and Latinx patients, such that we can try to diminish the disparities in death rates across racial and ethnic groups. And I'm going to end there. These are the 2 papers that I discussed. And then the third reference here is the Model Hospital Policy from the University of Pittsburgh, and it's available at that website. Thanks very much.
Thank you, Doug. Wow. So you do bring up many key issues. Let me start with just a couple that reflect things going through my mind, along with also some questions that are coming in. So couple of things. First of all, I remember Robert Brooke from RAND talking about when he served on an NHS panel that was put together by the British government in the late 90s or 2000s to talk about how they would spend a finite number of healthcare investments in improving the NHS. And they decided to prioritize investing in things that would narrow disparities ahead of things that would improve health for all. So in other words, if an intervention helped everyone but didn't close the gap, that would be assigned a lower priority. And that seems similar to an issue you're bringing up here, where you might actually, while, for example, white individuals might benefit from remdesivir and the whole population would benefit from an evenly distributed policy, you would actually favor a policy that might weight towards those who have historically been on the receiving end of greater disparity. So that's one issue to ask you whether you think this actually ties to sort of larger framing issues about how one invests all healthcare dollars. And the second question, okay, go ahead, and then I have a related question.
Let me answer that one first. Yeah, I think you can actually, you don't have to call on historical injustices in this case to say we need to prioritize hard-hit communities. These communities are being hard hit now. So this is not, for example, reparations for past injustices. This is, we're looking at populations of patients and seeing that there are groups that are disproportionately dying. And so if we are to try to have fair outcomes across society, we need to prioritize treating those groups so that the death rates begin to look a little more representative of the population.
Right. So that's very utilitarian and pluralist. It'd be interesting if everyone agrees with that, but it's interesting because it might be an implicit social value, but people might not have actually thought through ahead of time what the consequences are.
Yeah, if I can say, Derek, this is a classic tension in distributive justice, right? The trade-offs between efficiency and equity. You have utilitarians on one side and egalitarians on the other, and they have been fighting for centuries. And I think that fight continues. What we've proposed is something of a hybrid between maximizing the public good and prioritizing lessening disproportionate outcomes.
Let me ask a slightly narrower question that gets very much to a comment made in last night's viewpoint. They make the point that you shouldn't consider compassionate use for groups that were outside the groups that had been studied previously in the trial because there's less likelihood that it would be beneficial. But some people are excluded from trials for not necessarily for efficacy reasons. So for example, prisoners are not included in the original trial, but presumably they would be candidates for therapy, or?
Yeah, so I think it's really important to draw a distinction between clinical criteria to enter a study and sort of the research ethics and research machinations. So for example, if patients are excluded from a trial, not on clinical grounds, but because, for example, they don't speak the language of that country, then that's an irrelevant consideration in my view. And those patients, I think a reasonable triage officer would look at that and say, whether or not they speak English or whatever language of the country they're in is irrelevant.
And if they were pregnant?
Well, pregnancy brings up different issues because some of these drugs, we just don't know whether the drug is particularly harmful or teratogenic. And so I would say that needs to be a somewhat individualized judgment about the safety of the drug.
So Howard, before you leave, it's Howard. You started by saying this is going to be the first of many, many struggles around rationing. Monoclonal antibodies, I think people in the US, there's some coalescing around that may be what becomes available first on a large scale. Convalescent titers or convalescent serum if it plays out and is successful. And the vaccine. In the US, we're not going to have 325 million doses of vaccine. Do the same ethical principles that Bernie and his colleagues and you have written about, do they apply in a similar way to each of these potential preventive therapies?
Well, so it's a really good question. I think the criteria for ventilators, ICU beds, and inpatient medicines are quite similar. I think we may see some very different allocation criteria for vaccines once they're developed. There may well be a priority for the patients who are at highest risk of death. So, in some of these frameworks, those at the very highest risk of death are not getting prioritized for inpatient treatments. That may not be the case for the outpatient setting, where we may say, listen, for vaccines, we want to prioritize those who are infirm, those who are of advanced age, and those who have chronic conditions. So, and from a justice standpoint, it really is critical to consider the particular therapy in question and what are the criteria that are most relevant to that therapy.
So, Doug, let me see if I understand. When you say prioritizing, you don't mean 100% allocation. You mean weighted allocation, but it's still a lottery. And so if there's only 10% of the need could be met, even though some groups might get 15% access and others might get 5% access, many people will not be getting it. And so do you see this then as an opportunity to actually learn? In other words, for someone to be in the lottery, should there be an agreement that information about what happens to them, regardless of whether they get the therapy, should be included in a national database? It's essentially a large randomized trial.
Yes, exactly. So what I'm on the advisory board for the state of Pennsylvania, and we are trying to convince the state that the allocation of drugs, let's say that there are 100 doses and 1,000 patients who want it. That means each patient has a 1 in 10 chance to get the drug. In the allocation lottery, which would be a weighted lottery, we propose that all the patients should be followed, because this, as you said, this would be a natural experiment in the sense that we would have the ability to look at, for each of these scarce therapies, does it actually help in real world effectiveness outcomes? And this is a way to learn as we go, and also to give everyone a chance to receive the scarce therapy.
Okay, so I haven't been dinged yet by ESICM, but looking at the time, I know we have to be running late. So I think we should wrap. I have to say, this pandemic has put all of us in a place that none of us would ever have wanted to have been in, both for ourselves, for our loved ones, and for our patients. But it's also been a moment where we've seen much of the goodness and just the strength of character and devotion to duty among many of our colleagues, our colleague researchers, our colleague clinicians. And this session was one more example of it. For me, it was a great pleasure to hear the thoughtful and earnest way in which Doug and the other two speakers spoke. And so on behalf of Howard and myself and the entire JAMA family, we want to thank ESICM for this opportunity to host this little session for the last hour. Final words, Howard? Or?
Stay safe. And, I've never been more proud to be a physician and a provider than I have been in the last few months. It's an extraordinary profession. And I want to thank our readers, our authors, and our peer reviewers.
Thanks.
I'm a critical care nurse. I'm proud to work together with other professions as a multidisciplinary team to fight COVID-19. Together, we are intensive care.
I am an anesthesiologist and I'm proud to be an intensivist. Together, we are fighting COVID-19. Together, we are intensive care medicine.
I am a critical care nurse and perfusionist. I am proud to work in an intensive care unit. We are working together to fight COVID-19, and together, we are intensive care medicine.
I am an internist and I am proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
Hello, my name is Daniel de Bakker. I'm graduated in internal medicine and I'm an intensivist. Together we are fighting COVID-19 and together we are intensive care.
Hello, good afternoon, good morning, good evening. I am Giuseppe Citerio. I'm the editor-in-chief of Intensive Care Medicine, the Society Journal, and I'm happy to share this session with Joseph, the president, and with Maurizio, the president-elect. And in the next 45 minutes, we will have 3 outstanding speakers dealing with topics we already a little bit touched, research, physiology, and therapy. And I think that we have to say that intensive care, even if the journal is not a big journal like JAMA, did receive at least 50 manuscripts a day. And during this week, we publish 2 guidelines, the Surveillance Sepsis Guideline on COVID-19, and recently the guidelines on managing ICU surgery during COVID. And I think it's been a pleasure that all the manuscripts immediately went to the Society website, and we were able to publish them and make them free for all the readership, for all the community, and make them available as soon as possible. I think has been a big success for our journal. I would move on presenting the first speaker and going toward the first lecture of this section. The next speaker will be Professor Perner. And Professor Anders Perner was a deputy editor of Intensive Care Medicine Journal since a couple of months ago when he finished his mandate. He's a close friend of us and is a very good scientist. He's working in Copenhagen, in the University Hospital of Copenhagen, and is the chair of the Scandinavian Critical Care Trial Group. And his focus research is mainly on sepsis and large randomized controlled trial. And I think it's a pleasure to ask Anders to present why we should not take shortcuts during this period, during this pandemic, and why we need to be rigorous applying science also in this time. Please, Anders.
Thanks, Giuseppe. Thank you for to the Society for this excellent webinar and the previous one, and for the invite. I was asked to discuss with you why we shouldn't take shortcuts, and I sort of added a subtitle here, in particular, not in a pandemic. I have conflict of interest in this area. We run the COVID steroid trial, which is funded by the Novo Nordisk Foundation and supported by Pfizer. So I guess the background question here is, does experimental interventions benefit patients with severe COVID-19? I would argue not, based on the low success rate of trials in acute care in general, drug development in general, drugs that we use against other respiratory viruses, our history of mediator modulation in ARDS and sepsis, and also the candidate drugs that are being used and trialed were actually not developed for COVID-19. So I think this should dampen our expectations. Our specialty, you could say, or at least we say here in Copenhagen, was partly based on another epidemic, the one on polio in Copenhagen in 52, and an experimental intervention, positive pressure ventilation applied to a virus disease. As you see, the care back then was much more simple, and I guess also the virus, at least the acute phase of the disease, was probably more simple than what we see now. So this is intensive care today. It's much more complex. And I think we've learned over the last 2 decades that any new interventions that we enter into this complex world is really difficult for us to show benefit for either patients or society. This has been shown again and again. Here's a pretty simple publication from good Indian colleagues who simply looked at RCTs of acute care interventions published in the New England Journal of Medicine in an 8-year period, 63 trials together. Most of them, as we know, were neutral, so no effect on the primary outcome of the intervention. 10 improved the primary outcome, and an equal number, 8, of the interventions worsened the primary outcome, which I guess in general dampen our expectation of new interventions in general, and should obviously do the same in the present situation. The same goes for drug development in general. This simple bar graph shows the success rate of phase 2 trials, meaning that the program will proceed to a phase 3 trials. And again, the majority of programs are stopped here. So most drug development programs fail and are stopped before a larger trial. And this, I guess, is partly true for the other respiratory viruses that we treat and know well, flu and RS virus. The approved drugs for these respiratory viruses have at best modest effect, and therefore the care of the patients with these types of viruses is supportive. In that supportive care, in general, we have tried to modulate different mediators of mainly inflammatory responses for 3 or 4 decades in patients with ARDS and sepsis, and they have all failed, which again should dampen our expectations for the current situation, which is this. So new virus, new disease, we've only known it for a few months. As you saw in the previous session, there are obviously there are suggestions of targets for new interventions, as highlighted in the narrative review in JAMA. With this cartoon was published, I guess readers appreciate cartoons, and at least I appreciate the overview here. What I appreciate less is that this focuses on the efficacy of potential targeted interventions. Often, and also in this case, there's less focus on the potential harm, and therefore the balance between benefit and harm of either of these potential targeted interventions of the virus or COVID-19 is not truly presented in this cartoon, and it may therefore inflict false hopes. I said there are potential targets, and experimental drugs have been used in quite a number of patients with COVID-19 in ICUs. Here, two examples from China, from the ISAREC database, the latter being mainly originating in UK ICUs. And you see that half of the patients, both in China and the UK, have received a so-called antiviral drug. It's not further specified, but there are no proven antivirals for this virus. So these patients have received an experimental treatment. A lot of patients in both settings received steroids, and in China, more than 50% received IVIG. Similar in the US, a lot of patients, at least at this single institution, received experimental interventions, mainly hydroxychloroquine, but also again steroids, even IL-6 inhibitors, and some received remdesivir. It's beyond doubt that antivirals should be trialed and pursued. An antiviral game changers would be a game changer in this scenario. The sort of strange thing looking back was that this drug, an anti-malarial drug, known for years, was hyped first, and as you saw, used a lot. There are now more and more data to show, including now a randomized trial published this week in the BMJ, that this drug is unlikely to benefit patients and there are side effects. So a smallish randomized trial on patients in China with mild to moderate disease. Primary outcome was alleviations of symptoms, no differences in the group receiving hydroxychloroquine versus standard care, and there were more side effects in those who received hydroxychloroquine. The hype now is around remdesivir. At least now it's an antiviral drug, but it was not developed for SARS coronavirus. It was developed for Ebola, which I guess should reduce the a priori likelihood of benefit of this drug. Again, there is a fully published trial from Wuhan, China. Patients with moderate to severe disease, stopped early, unfortunately, for slow recruitment. Primary outcome time to clinical improvement, no difference. Mortality 28 days, also no difference. If anything, more deaths in the remdesivir group versus the placebo group, but as I said, low numbers. We already heard about the so-called ACT trial, stopped early. Results have only been presented at this press conference in the White House and in a press release on the NIH homepage. While the results appear to have a validity that the FDA has approved it for emergency use, I think the rest of us hopefully should be a bit more calm and await the publication of the full report, because there will be issues to discuss around this trial, the changing of outcomes, the stopping of the trial. So before we see that, and before we sort of at least mentally pool the results with those from the Chinese trials and those from other ongoing trials, I think we should be a bit calm with our expectations around the effects of remdesivir. Having said that, I think it's fair to say that it's not a game changer. Switching to mediator modulation, or trying to affect the so-called cytokine storm. Again, the narratives around this may form our expectations. The wording cytokine storm, I think, does not facilitate a balanced view on the potential benefit and harm of any mediator that will block or stop the so-called storm. obviously, the evolution has developed over millions of years and built a immune defense against the bugs. So any drug that will interfere with this adaptive system will be at risk of releasing the viral infection again. So I would highly question the use in clinical practice of any anti-inflammatory drugs, in particular those listed here, which appears to be used. I think, on the other hand, doing trials on these drugs is extremely relevant, and for patients to be randomized into a trial with any of these drugs, these patients will actually be better protected when exposed to an experimental intervention with obvious potential side effects because of the often more rigorous assessment of side effect, stopping of trial drug at side of side effects. In addition to the benefit for society and future patients that we produce trial results from which we can offer true learning of the effects of these experimental interventions. So adding this up, I think experimental interventions are unlikely to benefit COVID-19 patients because that's actually the normal in critical care. Once we introduce a new therapy in trial or in clinical care, then most often the result is neutral, so no benefit. And it's the same in drug development. In general, most programs fail. In our well-known respiratory viruses, flu and RS virus, we have no good intervention for these. Why should it be any different for COVID-19? All our mediator modulation trials have failed in ARDS and sepsis. Why should it be any different for a virus, a disease that we have only known for 3 months? I think the risk of harm is real. If you can, I think you should enroll your patients in trials, testing experimental interventions. Here are examples of 3 trials that are international and potentially available in an ICU near you. Thank you.
Thank you, Anders. And I think my first comment before leaving the floor to the other 2 chairs is that when we published the Survival Sepsis campaign on COVID, in which we don't insert information about the drug we thought were experimental without any proof at that stage, people was disappointed because everyone is looking for the magic bullet and try to find a drug that save patient. And I think that the journal, also the big journal, have a role in this game, reducing the enthusiasm towards unproven therapy. I would like to have your comment on this.
Yeah, I think we all have a role, but it's obvious the influence of the large general medical journals are large. So I think they have a specific obligation to ensure that the data that are presented in a fair and balanced way. And I think we have seen examples of publications that have not had this balance. And I would hope that there will be a time where we can evaluate on science publication, the dissemination of research results, and discuss if everything that we did was truly beneficial for community, patients, society.
Anders, can I ask you a question about what do you think about the data that you were showing? We have drugs for which we not only were uncertain about their efficacy, but also about their safety. And you showed that, for instance, for chloroquine, it almost became a standard of care, but even for IL-6 inhibitors, up to a quarter of patients received it. Do you think that one of the problems is that we're not used to think as doctors in statistical terms? I suspect very often we jump from causality, from one drug given to this patient to the effect that we're seeing in that patient. So clearly, with COVID-19, we don't have 100% mortality, luckily. I think we should be happy about that. But if you don't have 100% mortality, I think it becomes impossible to jump to causality with the fact that a treatment is associated with survival. So that was my first question to you. How do you think we could work on that? And maybe it's something that also Giuseppe could comment. But also, considering so many patients have been treated to this, do you think that could be an opportunity from registries or sharing data on this and maybe some proper propensity score matching to explore at least all these treatments that otherwise could be wasted information?
Yeah, I guess done is done. So we should obtain the information that we can get and analyze the data as good as we can. But I will submit that there will be confounding by indication, and critical care is extremely complex, and in our specialty in particular, confounding by indication and time-dependent interventions is extremely difficult to control for. So I will fear that any non-randomized data on these interventions, the results of these analysis will still be flawed. So I think there is a missed opportunity that these patients were not randomized.
Anders, can I just maybe make a comment there? Because when we talk together, we all agree that we should not give an unproven medication. We also agree that we can use it during trials. But if you see the use of it is tremendous. One of the previous speakers has even indicated that companies are working like hell to produce these unproven drugs. And when you also hear, it's a little bit also a competition, who is going to get that first and which patients should receive it. Is there, from my point of view, I think there is also a bit of panic action, because we are confronted with huge amount of patients in very short time. It's as if we are throwing everything in the patient, what we can find. What do you think about that?
Yeah, I think you're right. Hopefully it's not panic, but it's hope. But also a bit naive, I think, looking back. I think the worst thing that could probably happen is that we only prolong death. So by giving experimental interventions in the midst of a pandemic with scarce resources, the worst result will be, and you could probably see this happen with steroids, that you sort of stabilize the patient, but he or she still dies. So now you have used resources on a patient who ended up dying anyway. So I think that mainly driven on hope and surrogate markers, physiological success, improved oxygenation, reducing CRP levels based on experimental drugs will make us happy, and we think we are doing a good job. But it's difficult for us to see the longer course, even for a specific patient, to sort of put together what we did 3 or 4 days ago is now playing out in this specific patient now. So I think our bias and perception of benefit and harm induced by the interventions that we gave is something that we still struggle to handle.
And the last short question. You started talking about the polio epidemics and ventilators, and we learned something at that stage. What can we learn from the experience we had during the last month for the future? Because probably we will face a new epidemic in, say, 10 years, hopefully, not next week. But I think we need to learn something for the future, too.
Yeah, I think we have learned that we can do tremendous things. I mean, what this community has done in this pandemic has been amazing. We have stepped up. We have saved many patients' lives. We have organized hospitals in a new way together with nurses, managers, everyone. And I think we have led this, and therefore we should come out with high pride from this pandemic and use probably this position to increase the collaboration and prepare for the next events. And in that preparation, we have to be better prepared to do trials. So the platform trials that are now being built should probably be strengthened, and more of us should be involved in these trials and be better prepared so that we do not miss the opportunity to randomize patients from the first day. So now all these patients have been exposed, as you saw, to experimental therapy, and we have learned very little. That's a lesson that we should take on forward to be better prepared on the research side.
Thank you very much, Anders. And I think we need to move on for sake of time. And thank you. And I think we return back a little bit to physiology with the next speaker, because we were not able to run a big randomized control trial producing evidence in front of this new pandemic. And the next speaker will be Luciano Gattinoni, that is going to present about previous evidence to not apply to this, use physiology. And Luciano is emeritus professor in the University of Milano since 2017, and now is guest professor in Germany in Göttingen. But I know Luciano since here, and I'm happy to see him now connected, by he's always on the Italian TV speaking about everything, about COVID, hospital, life, music, everything. So I think will be interesting to hear from him, because he have a very deep insight in physiology. We already touched with Laurent Brochard earlier, physiology, and I think that in the paper he published on intensive care in another journal, he tried to stress a couple of concepts like that we probably didn't understand everything on the disease since the early phase. Please, Luciano, I think you are connected, and could you hear me?
Yes, perfect. Alles klar. Thank you for the invitation. And well, this marathon, the runners are not so speed, are quite slow, but I try to recover some of the time. And let's see, I would like to focus on very few concepts. Let's see here. So you can look, these are 16 patients, but these were an example, because what I'm speaking about come from the analysis of data and a lot of conversation with several people. In Torino, in Milan, we have a Chiumello in Milan, the Hospital of Parma, Brazzi in Torino, Foti in Monza, Lorini in Bergamo, Cairone in Torino, Camporotto in London, Berra in Boston, Massachusetts General, part of the Massachusetts General. And all agree on some very simple concept, that I'm working since 40 years with the RDS patients, and I never saw so many patients to have so big compliance, about 50% greater than 50, associated with so deep hypoxemia. So it's not a question of compliance and hypoxemia alone, but the combination of the two, which is striking. And I speak of course, at the beginning of the disease, this happened. So I may have a patient like this, and you see we have some ground glass operation, and we have a patient like this. And this looks as what we call the classical ARDS. Well, great, but look at the PaO2. We have exactly the same oxygenation in these two patients. Wait, sounds a little bit strange if you are accustomed to see CT scans of the patient. Okay, so oxygenation is an oxygenation that we call it moderate ARDS. Look at the lung weight. Here we have 919. The normal lung weight should be around 800. Here the lung weight is 2 kilos, 2000. The compliance, surprise, here is 27. Here is about 60. And you see, okay, these are exceptions. Huh? These are the black swan. It's not like this. This is quite common feature of this patient to have a patient with, as an example here, PaO2 at 5 or 200. 100 means very severe ARDS. Here is 100. Lung weight is 1 kilo, 0.2. Here lung weight is 2 kilos. Lung weight means edema or fibrosis or something mass. And compliance 55, compliance 67. I mean, you may call it ARDS, I don't care. But below the big umbrella of ARDS, this patient behave in a very strange manner at the beginning. You have a black lung full of gas and very deep hypoxemia. Full of gas means good compliance. I heard some papers saying, my God, the compliance, this patient, we looked at the CT scan and we found that the bad lung, that means the white lung, in a semi-quantitative way, is not correlated with the compliance. So these are normal ARDS. My dear friend, remember that since 40 years, the compliance is not related to the bad lung, but to the good part of the lung. So here we have in this patient, I have more gas than here. What we measure with the compliance is the good lung, not the bad lung. Anyway, this maybe I was blind before, or I'm blind now, but I never saw a big series of patients presenting in this condition. So, and what we learn? As the gas exchange is mathematics, if I have a lung which is full of gas, with the recruitability is low, the non-aerated tissue is almost zero, if the hypoxemia is relevant, means that the problem is from the side of the vessels. There is not a third way, gas or perfusion. Here, in classical RDS, the disease usually eats the gas space, and we have the baby lung. Here, we remain with an adult lung full of gas, good compliance. A lot of disease outside the gas space. And so it becomes more and more clear that we have endothelium inflammation with hypercoagulation, thrombosis everywhere, in the lung, in the liver, in the kidney, in the brain. And in the kidney, we have the loss of the vasoregulator, the tone, and that means a VQ mismatch. And we are creating evidence that I suggest you to read some of the papers which are coming out recently. Just saying that, you have a deep hypoxemia with a lung like this, because just the perfusion is badly distributed. You have overperfusion in some part of the lung, which cause low VAQ and explain the hypoxemia. Remember, VAQ distribution, maldistribution, is one of the more difficult concepts in the lung physiology. If you want to understand it, you have to study. There is no way, no escape. But very basically, if you have a lot of fluid, of blood flow perfusing one part of the lung, it's difficult to oxygenate. If you have a lot of blood flow in one part, you have less blood flow in another part. So in one part that goes toward the gas exchange, the other part goes toward the shunt. This is very rough complication, but this explains why in a beautiful lung like this, you may have this disaster of hypoxemia. When you have an hypoxemia and you have other reasons which are due to the disease per se, you have inspiratory drive and we have a tidal volume increase. Now, if I have a respiratory drive and increase, if I need a deeper breath and I get what I expect, I have no dyspnea. I have a deeper breath, I have a greater transpulmonary pressure, but I don't have any dyspnea. When the dyspnea occur when I try to expect some when I inhale and I don't get it. And why this happened? Well, this happened for the damage progression. At the beginning, we have a patient with a very good compliance, low VAQ, low lung weight, low recruitability. And they may progress in non-invasive support. We call this type L, which is that form of communication. It's not a dogma, but they can stop at this stage. Or the people start to be correct hypoxemia with non-invasive ventilation, okay. But if the patient continue to have a deep breath and the disease progress, we go toward the classical ARDS. So it's important to realize that the disease can go in some patients, fewer and fewer in terms of incidence, toward a very bad ARDS. But in some patients, they can stop at certain level. Now, this is a CT scan of a friend of mine who died. And you can see here, this is a CT scan, PO2 FiO2 95. Here, PO2 FiO2 84. Look at the CT scan. This is well-aerated lung. 5 days between here and here, 7 days, of a tremendous inspiratory effort, despite mask, then CPAP, then non-invasive ventilation. The key point is if the patient continue to have a very big breath. At this point, we have a negative pressure inside, so the pleural pressure goes down. You can look at the central venous pressure as an example, which kind of swings, or you can measure the esophageal pressure, and you may record -20, -30, which add damage to the disease. And then we have, of course, the possibility, which is the natural course of the disease. What can we do? Type L, light, non-invasive support, there's no problem. You can give non-invasive support, but how much? If you use the PF table and so on, you kill the patient. You may start anyway with 10, maybe 15 of pressure and see if the hemodynamics is okay. But more important, if the patient produces vigorous inspiratory effort. If he continues to breathe as a hell, we have a ventilator-induced lung injury, self-induced lung injury, which is phenomenon which is known since decades, has been re-emphasized in the last 2 or 3 years, but was described by Barak in 1938. There are beautiful papers on this aspect. And in this patient, if the non-invasive support is unable to stop the effort, I think the mechanical ventilation, not just to substitute the muscles, because the compliance is good, but just to prevent and to stop this progression. It's the only thing that we can do. Then, FiO2, tidal volume. Oh, this is scandal. Tidal volume greater than 8, than 6, up to 8, 9. What is the problem? We have at least 3 randomized studies that didn't find any difference between 7, 8, 9, and so on. 3 bigger studies than ARMA trial that people completely forget. If I have a good compliance, I'm very far from the threshold of plateau pressure, driving pressure, mechanical power, etc., etc. I prefer to keep the patient quiet without to be obliged to very heavy sedated and without hypoventilate him. Hypoventilation means reabsorption atelectasis, respiratory rate, and PEEP, not much. 8 to 10 is even too much. To the minimum PEEP available. Prone position, okay. Prone position always. 90% of the case improve oxygenation. In this case, because of fluid diversion, not because of very recruitment and so on. But when you put the patient again, as you lost the control of the regulation of blood flow, the patient usually goes exactly back as he was. As a rescue is okay. Then we have the type H. And this you can play with a classical, almost classical LDS. Because I'm afraid in this patient we have something more. But okay, let's accept now this is a classical LDS. In this patient, FiO2, tidal volume, of course, you try to protect, you may apply the standard treatment for IKLDS, and PEEP, no more than 15, even in standard LDS, please, and prone position is absolutely okay. Weaning may be very difficult because some patient also has some neurological problem. So don't try to accelerate the weaning. We need time for the pneumonia to solve. So, when I conclude, more than 50% do not have the classic RDS. Classic RDS, I mean baby lung. Here is adult lung. It's a long course disease. 10 centimeters of PEEP is okay. And the best that we can offer to the patient. And I thank you for the attention if somebody is still there at this time of the afternoon.
Thank you very much, Luciano. I think that everyone is there because they are waiting for your talk. I think that all the letter we received after the paper on intensive care didn't understand fully the concept that you were presenting, the evolution of the disease, because probably people want to have very simple rules to apply. And as you said, physiology change over time, and you need to think about the phase in which the patient is, and you have some trick for avoiding the evolution, as you wrote. And I think physiology will return back because fill a hole that randomized control trial in this setting could not fill. What do you think about that? We manage the patient.
I mean, the most damaging or the most harmful thing that people can do is to say, now I have the cure or I have the recipe for this patient. Does not exist to me. An ideal treatment of this patient depends on the stage that the patient is. And remember, we do not cure the patient. We have to keep the patient alive. We buy time waiting for the antibodies, normal antibodies to react, and waiting for some magic pill. So we do not have to add damage. And if I take a patient with adult lung, not a baby lung, and I put 20 of PEEP, following the PEEP table, I kill him. Because the lung becomes 5 liters, the heart disappears, the hemodynamics start to have a problem. You have to give cardiovascular drugs, the kidneys start to fail, etc., etc. So you have to be extremely quiet and prudent for this patient and to understand at which stage we are. Of course, these patients have to be anticoagulated. Look at the CO2 during the evolution, because when for the same ventilation, the CO2 goes up, means a progressive structural changes of the lung, of which the microthrombosis may be an important piece of the puzzle. So anticoagulation in this patient, we don't have time to speak about that, and the lung treatment as gentle as possible, without trying to anticipate the times.
Thank you.
Luciano, can I ask a question? I think we've treated probably, I don't know, 100, 110 invasively mechanically ventilated patients. And I agree, probably the majority of patients had a compliance of more than 40. But for me, that's still ARDS. I mean, the difference, I think, this time is that probably in the past, in sepsis, in ARDS, we always had syndromes. For me, what has been surprising for me in this career so far is that I never had in my career a single disease. And this is the first time that we get so many patients coming with the same disease. So it is true that very often you find very high compliance, but I would argue that it's still part of ARDS, and probably even in ARDS, we should not treat the patient always with the same recipe. So the individualization of physiology should be there anywhere. Are we not running the risk to create from one dogma another dogma?
Okay, I'm trying not to have a dogma in my life. You can call as you want. You can call also people. You can call respiratory failure. This is not important. Under the umbrella, RDS is nothing. It's a word of communication. I say RDS, you imagine white lung, at a CT scan, low compliance and low PO2. What struck me is at the beginning, this patient do have adult lung full of gas, a tremendous hypoxemia. And this in the classical RDS does not exist. Call atypical RDS if you want. Call COVID pneumonia, which is the right name. But if you apply the PEEP table of the classical RDS to this, you kill the patient. And of course, when you see, I see my average is 40, means that you keep the patient or you have treated this patient after probably days. Because I think the game for this patient is played before the intensive care. It depends. If you keep the patient with pneumology, maybe with a helmet, with a CPAP, with mask, with a tremendous inspiratory effort. Nobody measured the esophageal pressure in this patient. We measure down to 30. If I take an animal with minus 30, I kill an animal in 24-8 hours, a normal animal. And I think at the beginning of enrollment, because now the people learn to use lower PEEP and so on, I think the people start to learn some. But when I read in New York, 88% of mortality is only mechanical ventilation is dangerous, depends what kind of mechanical ventilation you apply. Mechanical ventilation per se doesn't mean anything. And these patients do not have a recipe or a protocol. You have to follow them day by day. And they have also a tremendous capability, more than classical ARDS, at least that I saw in 40 years, of fibrosis, which I think is the other side of the thrombosis. Somehow they are linked. The fibrotic activity in this patient is terrible. The response at CT scan proposition, I didn't show you anything about that, is completely different from what you are used to see in ARDS. So you can call as you want, I don't care. But I care of the treatment. And the treatment is not uniform.
I agree with you entirely. I just suspect that probably individualization of the mechanics and what we do with the ventilators, it's always the same in every patient, not just on this one. Even in ARDS, we should not apply recipes.
Try to speak with our American colleagues, how they do personalize the treatment of this patient. They take the PEEP table, PF table, and they apply. If you call it personalized, okay, go ahead. I don't do it. That's it.
I think that Joseph had a very short question for, and I think it's the last one.
I had, but Luciano has answered. It was about the thrombosis factor, about lung circulation, because we have missed that at the beginning when the patient started to come in masses. But maybe I can just ask it a bit bluntly, but can we say that because of our respiratory strategy, one lung of the COVID lung, which is quite clear in the CT scan, we converted to a real ARDS lung. Is there also a little bit of technique that we are using, which is causing that?
Well, I'm not sure to have got your question, Joseph. Can you summarize?
We see that, we see mostly that, as you indicated, the lung is quite compliant in the first days, and but sometime later, we also see the same patient switching from the compliant lung also to having the characteristics of a full-blown ARDS lung. Something like in 5 days, or is that, can we really can we say that we are doing that with our ventilation policy?
Well, absolutely is true, and I think we have only two explanations. We have two explanations which are not mutually exclusive. One is the natural progression of the disease. Of course, if I start to have a lot of thrombosis and so on, I have a lot of problem and fibrosis which continue. So we have the compliance goes down, the edema start to increase, the edema is substituted by fibrosis and so on. But we have another possibility, that these patients were badly treated. Badly treated means maybe patient treated with pressure support, or patient in whatever system you want, but with still the capability to have a deep breath. And this is the only thing that we can correct. We cannot correct the natural progression of the disease. We are not able to do it. But we can prevent the ventilator-induced lung injury, self-inflicted lung injury. This is the only thing we can do. So please, try to look in those patients, look at, as an example, the central venous pressure. And look how much are the deflection of the central venous pressure. Put an esophageal pressure in the esophagus and see what's happened. After that, we start to discuss. Not before. Because this is the problem. And in Italy, at the first week, this patient had average PEEP of more than 16. After 1 month, were around 8. Not the same patient, of course. The patient coming after 1 month. Why? Because the people learned. Without maybe many physiological background, but learned.
Okay, thank you very much indeed, Luciano, for your time. And I think we are ahead of time since the beginning of our talk, but we are more ahead of time now. Thank you for your insight about ventilation. And I think the last talk of the day, after discussing many topics from ventilation to therapies to failed trials or to trial we didn't perceive that during this pandemic. And the next speaker will talk about the truth at the bedside. What should I do? And it's a pleasure to introduce Professor Richard Beale from London. He is Professor of Intensive Care at the King's College in London. And he is part of the steering committee of the Surviving Sepsis campaign since 2004. And he was a member of the society, was the research committee chair of the society some years ago. I see Richard there. Hi, Richard.
Hi there. How are you?
Hello. Please,
can you hear me
can.
all right?
Please.
Are you hearing me?
Yeah.
Yes, we are hearing you.
Excellent. Very good to hear from you both. Shall I kick off?
Yeah.
Okay, so I want to do two things, if I may. Firstly, share some of our system experience and then share some of the lessons from the bedside. And as a background, healthcare in London is organised across 5 sectors. And where I'm based, King's Health Partners, is the southeast sector. King's Health Partners is comprised of 2 major teaching hospitals, Guy's and St Thomas's, with 2 sites, Guy's Hospital at London Bridge and St Thomas's at Westminster, and then King's College Hospital. And then we have the associated district hospitals, the Princess Royal, University Hospital Lewisham, and Queen Elizabeth Hospital in Woolwich. So 2 tertiary centres with 3 sites, 3 district general hospital sites, and between us all, 5 emergency departments serving a population of about 2 million people. Now, of course, we had warning of the COVID scenario, particularly based on what had happened in Italy and elsewhere, and our Italian friends had been enormously generous in sharing their experience. So we'd all started to plan, based on previous pandemic plans, to at least double critical care capacity. We'd ordered extra equipment as much as we could, allowing for the shortages which were already emerging. We'd stopped elective work, and we'd started surge staffing and training staff up. The other thing we did was, in this sector, we set up a network hub for which I was the clinical director. And key features of this were to use our 3 organizations as one, to have our own meeting and support capability with senior managers, project leadership, who were supported by Boston Consulting, who had been working with us on other projects and were very helpful pro bono. And crucially, we developed very early on a sector transport team. And this just gives you some idea of the pattern of COVID cases in Southeast London. And you can see, it started earlier than this, earlier in March, but you can see this rapid rise, and each of these is broken down to the colours of the different hospital, Guy's and St Thomas's, King's College Hospital, the Pru, QEH, and Lewisham, our 5 hospitals. And you can see the rate of rise, up and down, obviously more at the beginning here. And we also looked at capacity modelling on a daily basis, following what had been going on up to the point at which this particular analysis was done, looking at our critical care capacity and our surge plans to increase it, and trying to get some idea of the future. And this just shows what actually happened going further forward with the same sort of format graph as I showed you before. And you can see we peaked in terms of ventilated patients. These are all ventilated patients at 268 in our sector in Southeast London, 109 Guy's and St Thomas's, 86 at King's College Hospital, and the other numbers you can see. And then if I bring us up to date, you can see the volumes falling substantially, and day-to-day admissions are much fewer, only a handful of cases across our sector now, and most of what I'm showing you here represents the tail of these patients who are ventilated for a long time, very slow to recover. The transport service was crucial as well. A locally run and staffed critical care transport service established from the outset. And the key reason for this was that this is essentially a disease of local outbreaks. So all our hospital emergency departments were likely to see similar attendances, reflecting the population around them. And the only way to keep our district hospitals functioning, together with their emergency departments, was to offload them by transfers to the 2 big tertiary centres, which of course have much more capacity and much more surge capacity. So during this period, these are the numbers of patients we moved. And at one time, we had up to 5 retrieval or transfer teams staffed by critical care transport experienced doctors, nurses, and paramedics on the road at any one time. The need for this has dropped off, and now it's mostly doing repatriations. Now, at the same time this has been going on, our Intensive Care National Audit and Research Centre has also been looking at what's been going on in the UK, or particularly in England. And this is all available publicly on their website. And this just shows you the pattern in critical care across England. And you can see the peak of admissions corresponds pretty much to our own peak of admissions, the beginning of April, end of March. And of course, there's still patients who've got incomplete data, just as in our own hospitals. Critical care in England is organised in one respect around what are called operational delivery networks, covering the whole of the country. And you can see that South London so far has had the largest number of COVID cases of anywhere in England. And ICNARC have given some basic demographic information. There's much more in their report, which you can download from their website, and they keep updating. But you can see, broadly speaking, about 60 years old and about a 71% or 70% preponderance of males. Now, when it comes to outcomes, again, many patients haven't completed their critical care stay, but of those so far in the ICNARC report, perhaps a third, slightly more, have died so far. When they look at patients for whom they've got the first 25 datas and they've got survival and discharge information, you can see that overall in England, the mortality is running at around about 50%. For patients who've been receiving advanced respiratory support, which means intubated and ventilated, in the ICNARC report, the mortality so far is nearly 60%. And those who've received renal support, and if I go back, you can see that of this advanced respiratory support group, about a third, 32%, have also needed renal support. And in the ICNARC analysis, those who've needed renal support have about a 70% mortality. Now, at Guy's and St. Thomas's, this reflects our own peak of activity, pretty much the same as in the sector numbers, as you'd expect. These are our admissions, and they mirror the profile I showed you on the ICNARC report. And so far, around about 300 ICU admissions at Guy's and St. Thomas's. You can see the age distribution. This is the biggest group, the 50 to 59-year-olds, followed by the 60 to 69-year-olds with the same preponderance of men. This just shows you the ethnicity distribution. This is clearly a hot topic at the moment, but we haven't been able yet really to analyze this properly and understand to what extent this differs from our own very diverse local population. So that's work to be done. And this just shows you that we still have patients with incomplete outcomes, but our intensive care mortality is currently running at around about 32, 33%, which is lower, of course, than the ICNARC number, but it's important to say may be confounded by the fact of all those transfers in from our district hospitals, because of course, the patients who are transferred tend to be a bit more stable. And so we will look at a whole sector level analysis to get a true understanding of what our outcomes have been. And this is important, not just to know the answer, but also in Southeast London, we've taken a clinical approach, slightly different from many others in the country, where we very much preferred the idea of not using much CPAP and non-invasive ventilation. If patients are not coping with conventional high concentration oxygen therapy, if their respiratory effort has been too high, we've preferred to move to early intubation. So there's also a question of whether these numbers include patients who were intubated early and might have got away without intubation elsewhere, or whether it's a benefit of early intubation. And of course, it's too early to know the answer to these questions. This just gives you a picture of the overall situation in the hospital, showing again the distribution of admissions, the cumulative data. Guy's and St. Thomas has seen just over 1,200 COVID positive patients as a hospital, and the overall hospital mortality, so this includes all those patients managed on the ward, predominantly, as I say, with high concentration conventional oxygen therapy, self-proning and good general supportive care, plus the intensive care cohort running about a 20% mortality. We're also one of the 5 severe respiratory failure centres, so we provide ECMO. We've provided ECMO for 52 patients so far, 11 are still on VV ECMO, but of those who've been discharged, the survival rate is currently 71% for ICU survival. Yellow is, of course, response to the whole hospital, and all clinical groups being drawn in a task-oriented approach with pruning, intubation, vascular access, and tracheostomy teams, and a huge logistical effort. The sector response also crucial because the small hospitals would not have coped without being supported, and if they'd failed, the larger hospitals would also have been overwhelmed. So mutual cooperation and that transfer team was crucial. And of course, this phase seems to be passing, but there's much to do preparing for a second surge, learning lessons, figuring out what to do better, making ourselves more resilient, re-engineering our models of care to try to start to treat non-COVID patients again and keep the best of the new ways we've learned. And of course, debrief, support, and provide staff downtime. Now, what about the bedside, where I've also spent a significant amount of time? Well, what I would say is a lot depends on the circumstances. One of our German colleagues gave us a webinar and was explaining the advantages of high fidelity, individualized, proper intensive care in these patients and how they were relatively easy to ventilate and did well. That's a different experience from ours, but I think the numbers he'd seen were much smaller. In surge, the first thing to say is you do the best you can. You have to keep it simple. You can't rely upon complex monitoring and forms of ventilation that bedside staff who may not be intensive care familiar don't understand. For most of the time I was working clinically, I had one anesthetic or intensive care fellow. I was in a 13-bedded unit that had up to 24 or 25 patients, probably not 24, I think, at the maximum. And so 2 patients in each bed space, doubling up on the pendants. And the rest of the staff, although plentiful, came from transplant surgery, from ophthalmology, from general medicine, from general surgery, and the rest. You have to be prescriptive. Plans have to be specific and unable to be misunderstood. Basic targets for blood pressure, fluid balance, and ventilation are key. Things that everyone can understand and work towards, and you can change readily if they're obviously not working. Interestingly, for me, in many ways, it was like the intensive care I was used to when I was a fellow many years ago, when ARDS with multiple organ failure had a 60% mortality, when patients were over-sedated, when secondary infection was commonplace and we thought it was normal, when complications of ventilation were routine, and when prolonged ventilation was injurious. Because there's no doubt, going through all the different ventilatory strategies we all try on people who are difficult, who don't get better properly, who are on a ventilator with high pressures, with high FiO2s, that some of what we're seeing, and maybe quite a lot of it, is not just the hyperinflammation and the intrinsic lung injury, severe as that may be, but it's also ventilator-induced. Specifically, low as possible intrathoracic pressures, I'm unconvinced about the value of APRV in a routine approach to these patients, for many of the reasons Luciano has just alluded to, although some patients clearly do benefit. So what mustn't be dogmatic, it's a matter of what works, and what works at different stages of the illness is different. If you're allowing spontaneous ventilation, the drive is high, even on the ventilator, and if there are areas of dense consolidation in particular, then there are big intrathoracic negative pressure swings with marked intercostal recession, particularly in the areas that aren't moving at the bases and posteriorly, paradox, and these big CVP swings, which you can measure. It's not unusual to see a CVP negative swing of 20 to 25 millimeters of mercury. If this is too much, then maybe they're better if you prone them, maybe if you paralyze them, maybe if you suppress the ventilation, but you have to reassess and see what works. If allowing spontaneous breathing, which is clearly necessary for some of the time, particularly in the later phases, then modes with open valves, by or APRV, even if not used conventionally as APRV, may be helpful and may improve synchrony. Similarly, personally, I find PCAC as a spontaneous mode, so with the spontaneous rate higher than the set rate, is a better way of matching precise inspiratory time to patients than using pressure support. And I absolutely would switch the tube compensation algorithms off. They get in the way and don't help. Respiratory rate is going to be rapid. If you do this, accept it. Don't dehydrate. Intrathoracic pressure and hypovolemia increases renal failure. And you see patients where people pleased because PRV and better oxygenation, but actually there's also increased CO2. So maybe that's just recruitment and a lower minute volume, but maybe it's overdistension and cardiac output reduction, giving false security. Volume challenges often improve oxygenation in this context. Sedation is a problem when you're using drugs we stopped using, like morphine and midazolam, high-dose oxycodone, NG-diazepam, because normal agents are in short supply. Patients don't wake up. We know that midazolam has metabolites, particularly in renal failure, that are active for up to 3 weeks. So much delirium is emergence. It's difficult to disentangle. Bowel stasis was a huge problem, and near-statement infusions can be safe and effective and really improve ventilation if the abdomen's distended. Washout periods with propofol, if it's available, can be helpful. And absolutely, old-fashioned sedation holds were meant and were proven in this sort of scenario, not when you're using modern short-acting agents. Infection control, a real issue. This difficulty between PPE for staff and preventing transmission between patients. Often what people say is late hyperinflammation, although it obviously does happen, is actually sepsis, with bacterial and fungal infection an issue, line infections, chest infections. And remember the basic principles of observation and examination. Expect problems, line disconnections, blocked filters, getting wet, using filters on the expiratory ports and not changing them frequently enough with wet humidification is a problem. Tubes down too far. And be patient with yourself and others. Mistakes are inevitable. Learn from the new things you're seeing and the old experience you're recalling, and the skills of others, surgeons and physicians from other areas with different perspectives. You can still do proper intensive care, more or less, but it's difficult and challenging. And I suspect none of us will ever forget this experience. I'll stop there.
Thank you, Richard. I think for sake of the time, we have a short question from Maurizio, and probably we need to move toward the conclusion in a while. Please, Maurizio.
Hi, Richard. I was impressed by the volume of Ecmo that you've delivered. And I was interested to know if you found differences in outcomes in patients matched by age and risk factors compared to the ones that you were managing in just with ventilation, because I saw that your data for mortality from ICNARC is around 50% for probably 28 days mortality, unless I'm wrong, but you were reporting a very good survival from ECMO discharge. So was it a patient selection made with very young patients and so on, or just a comment on that? I was surprised about the volume and the outcome you reported.
So the ECMO system has surged along with everything else, and my good friend Luigi Camperota can give you better information than I can on the details of the ECMO. But in the general sense, all the ECMO centers surged. They all saw pretty good results. In the early phase, there was concern that these patients might do less well. What is key, though, is the selection criteria have been narrowed. So in addition to the normative selection criteria, the RESP score, the Australian RESP score, has been added. And that means that the patients are probably a bit younger, and crucially, if they've been mechanically ventilated for too long, they're excluded. So partly this was to deal with the capacity issue, and partly it was just to try and make sure that patients with the best chance were being offered ECMO. So I think there's still a lot of learning from that, but nevertheless, within the context in which it's been done, the ECMO results seem encouraging and do suggest that it's been a worthwhile intervention.
Thank you.
Thank you, Richard. I think we are far away from the closing time we were planning. So I think that Joseph could close this session and thank everyone that did participate. Please, Joseph.
Thank you, Giuseppe. I would like to say that I hope you all agree that what we have heard this afternoon has provided more insight and also clear indications of the lessons learned since the outbreak of the coronavirus and what we can do to endure both. And I hope not, but unfortunately, maybe the next phases. I would like to thank all the presenters, moderators, guest speakers, and social media team for taking the time to speak to us and passing on their vital knowledge and experience. I also wish to thank you, especially you, the audience, for joining us today. I hope that you have found this a valuable use of your time and you are ready to continue your work with extra confidence and assurance. Just want to remind what Mauricio at the beginning has said, Alive, our foundation for education in low and middle income countries. There are a lot of good work being done there. Support us, please. Finally, I want to acknowledge many companies who have supported today's webinar and who clearly want to assist us with the provision of essential education that we make available to the global intensive care community. Please continue to look to European Society of Intensive Care Medicine for help and assistance, all the latest information. We are continually updating our COVID-19 resources webpage and our regular 1-hour COVID-19 webinars. We really hope to see you in Madrid for Lives 2020 on the new dates of 5 and 9 December. Until that time, keep strong and stay healthy. Good luck and goodbye.
Ciao, ciao.
I'm an internist and I am proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
Hello, my name is Jean-Louis Vincent. I am an internist by training, but I am proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
Hello, my name is Stefan Schaller. I'm the chair of the next committee of the European Society of Intensive Care Medicine.
Hi, I am an anesthesiologist. I am proud to be an intensivist. We intensivists are working together to fight COVID-19. We are intensive care medicine.
I'm extremely proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.